Shock and Resuscitation. Here again is Dr. Gary Marshall.
Thank you very much. I'm Gary Marshall, and we'll be discussing shock and resuscitation, a little area a little more near and dear to my heart. So I have nothing to disclose here financially. I benefit not at all from shock. We're going to talk about shock. First, the definition, the pathophysiology, what is the normal stress response, and then the initial assessment. And this is key. Again, assessing shock is important. Figuring out that it's there is the most important aspect of dealing with it. We'll talk about the different types of shock, hemorrhagic or hypovolemic. This is the most commonly encountered by the general surgeon, is going to be some sort of volume issue. But then cardiogenic, septic, neurogenic, and adrenal insufficiency. And then we're going to get into the resuscitation, the initial management, the ABCDEs, and how they can be applied both as they apply to trauma and ATLS, but also in terms of any patient. And these work for sepsis, these work for just about anything that's going on. If you follow this approach, it will get you usually to the right place and the safe answer. And then talk about some life-threatening issues, special considerations, and then endpoints of resuscitation. So first, shock. The initial step, again, in managing shock is to identify the presence of shock. It seems like this is obvious, but it is not always there. It can be occult at many times, and you may have a patient that, although they look okay, their lactate is 6 or 7. You need to figure this out before they get too far down the road. There's no laboratory test, vital sign that will accurately diagnose shock. This is something I worked with trainees on, is that a blood pressure 80 might be just fine in one person. They might be making urine, have a good mental status, and living just fine. They are not in shock. Elderly woman at 90 may come in at a blood pressure of 120. Unfortunately, she lives at 180. She may be in florid shock and end organ damage with that normal blood pressure. So you have to have that index of suspicion and adjust your definitions based on what the patient that's sitting in front of you. The second step is to identify the source of the possible cause, what is going on in this patient. So by definition, shock is an abnormality of the circulatory system that results in inadequate tissue perfusion and oxygenation. Again, inadequate delivery of oxygen to the tissues is the end of all forms of shock. And again, there's many ways to find this. One of the ways to think about shock and its management is to remember that oxygen delivery occasion that includes cardiac output, heart rate, preload, hemoglobin, oxygen, saturations, all of those things. And then you can sort of figure out what's broken. And we'll talk a little bit more about that as we go. So you have decreased oxygen delivery, poor oxygen uptake and utilization, and this may be more common in, say, sepsis, where you have very high cardiac output. The tissues are just unable to use the oxygen that's presented to them. Let's see. So next question we'll have is, which of the following are part of the normal stress response to shock? A, increased cortisol. B, increased aldosterone. C, increased catecholamines. D, all of the above. The answer is all of the above on that. Okay. There we go. Everyone got it. So pathophysiology, remember, cardiac output is heart rate times stroke volume. Heart rate is usually constitutive. There are ways to control that, say if you're bradycardic and you need to pace or something of that sort. And then the stroke volume is dependent on preload, what your volume status is. Afterload, are you clamped down? What's going on the other end of the circuit? Is there some sort of obstruction? And then the myocardial contractility in itself. Remembering these three things will help you to remember how to treat that shock. What can you do? The first thing you want to do is maybe increase the preload, give a little bit of fluids, and then you can work on your afterload. Is there something you can reduce? Is there a tension pneumothorax? Is there something hurting you on that end? And then contractility, there's various agents and pressors and inotropes that you can use. Usually you get an acute vasoconstriction followed by an increased heart rate. So again, afterload is increased by that Vasoconstriction, this does get back some of that pressure within the system, gets a little more pressure to the head, maybe back to the coronaries. Remember, though, that you're sort of robbing Peter to pay Paul here, and then when you start clamping down, some of the organs are not getting perfused in this state. So even though you've clamped down, preserved your blood pressure, there's not flow to the distal toes, to the fingers, to the gut, and to several other systems. There's an endogenous catecholamine release, which again increases peripheral vascular resistance, increases diastolic blood pressure, and narrows the pulse pressure. So when you see some things, a narrowed pulse pressure where that diastolic is suddenly up is the first sign of shock. Before you get to the tachycardia and the hypotension, narrowed pulse pressure can show up. Again, easy to say in a textbook field, and when you're looking at some questions in practice, if you're in a trauma bay or somewhere like that, you're getting 80 over palp, you don't know what the baseline diastolic is, you don't know what it was late before, so this is more cerebral than what you may actually see in practice. But if they're getting very close, you know that something's going on and that there's a catecholamine surge. Within the adrenal axis, and this has become a kind of a hot point in shock and resuscitation over the last few years, the stress leads to sympathetic stimulation. You get to adrenal medulla and catecholamine, epinephrine, norepinephrine. So this is fight or flight, epi, norepi, just think of that. In addition, your cortisol will increase to help maintain blood pressure. Aldosterone, again, mineralocorticoid, will increase fluid retention and salt there. You'll have an increase in insulin resistance. If you think of the flight or fight phenomena, you do want glucose and substrate on board to utilize for energy. So you want to do things that would make the glucose readily available. And also growth hormone is increased. Within the pituitary and the adrenal axis, stress will cause the CRF, or corticotropin releasing factor, from the hypothalamus, then acts on the pituitary to release ACTH, which then acts on the cortisol, on the adrenal cortex, and then the aldosterone and glucocorticoids are increased. Within the renin-angiotensin system, you have kidneys sense that decrease in renal blood flow. They then release renin, angiotensinogen is converted eventually to angiotensin 2, and aldosterone is increased. Other hormones are released in the stress response. Histamine is one, bradykinin, beta endorphins, sort of a natural pain control. And there's a whole cascade of prostanoids and cytokines, interleukin 1, interleukin 6, TNF-alpha. Again, the specifics of these are more for ABSITE type exams and not for maintenance of certification type exams of which interleukin is elevated, and a fever is very unlikely to be how you're presented one of these. But it's important to understand the role in all of those and some of the effects that some of the drugs like steroids may have on some of these. The pathophysiology here is that because there's inadequate oxygen delivery, you now begin to have anaerobic metabolism. This eventually results in much less generation. Remember, you only get 4 ATP instead of 36 when you're doing this anaerobically. You will lose cellular integrity at some point. Glycogen goes very quickly, especially if you're in that flight or fight situation. You have eventually no glucose around, and you switch to protein catabolism to make sugars for ease of use. And this is part of the reason for, in the septic patient, the stress patient, all of the weight loss is frequently due to protein catabolism. So the initial assessment of this, or any patient, and this is taken from Advanced Trauma Life Support, ABCDEs. So early manifestations of shock include cutaneous vasoconstriction. One of the easiest ways is just to simply grab the patient's hand or their foot. If it's cold, something's going on. If those are warm, especially in a trauma situation, they're perfused. Altered mental status, the narrowed pulse pressure, and heart rate abnormalities. Again, none of these is perfect. We have all sorts of the elderly now on drugs that control heart rate. We have athletes. We have people. So knowing it's all sort of relative to what the baseline is. So there's different types of shock. Hypovolemic shock, this is loss of fluids in surgical situations. This can be like diarrhea, or from being NPO, or from having an aggressive bowel prep that you might go into shock, say on that when you're doing your colectomy because they lost 2 liters of fluids the night before, or blood loss. Then cardiogenic shock. septic shock due to infection, neurogenic shock, and then there can be other considerations such as anaphylaxis and adrenal insufficiency. This sort of Venn diagram shows that there's a whole lot of overlap in a lot of these. Pulmonary alveolus, this is sort of obstructive, but it also, because of that, can lead to inadequate perfusion of the coronaries, which then adds to a cardiogenic component. So there is some overlap, and sometimes multiple mechanisms are at play. Here's a question. 27-year-old male is an unrestrained driver in a motor vehicle collision. He's hypotensive and tachycardic. His mental status is altered. The most common explanation of these findings is A, closed head injury, B, cardiogenic shock, C, hypovolemic or hemorrhagic shock, D, sepsis. That's correct, hypovolemic or hemorrhagic shock. And remember, in the surgical patients and trauma patients, it's bleeding, 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 and then you start entertaining cardiogenic and spinal and the others as it's sort of an exclusion. In a surgical situation, because of the nature of surgery, what we do, look for the bleeding first. So hypovolemic, the most common cause, you can have external losses, blood loss, and then diarrhea, nausea, vomiting, drains that are high output. These can all sort of creep up on the patient and eventually lead them dry. So for the stages of shock, systolic hypotension is first seen in which class of hemorrhagic shock? A, class 1, B, class 2, C, class 3, and D, class 4. Class 3, that's right. And so I'm going to talk about more of these in the various classes of hemorrhagic shock, but hypotension is sort of late in coming. So all of these things that we were talking about for the renin, angiotensin, aldrin, the epinephrine, norepinephrine, all of these preserve blood pressure for quite a bit of hemorrhagic shock. You can lose quite a bit of blood before you start getting hypotensive. That's good for preserving the life, but it's also a little bit difficult because by the time you are getting hypotensive, you've lost 30 to 40% of your blood at that time. So you really are, that's not where you want to be picking up shock. You hopefully have identified it before you get to that point. So we'll talk about the classes of hemorrhagic shock. The first is blood loss up to 750 cc's. This can be like a simple phlebotomy. Up to 15% of your blood volume. Remember, we work with sort of a baseline in the 70-kilo man of about 5 liters. Pulse rate is usually normal. Blood pressure is normal. Pulse pressure is, again, normal. Just about everything looks fine. The patient may be a little bit anxious, but other than that, in class 1, you see very little physiologic effect. Class 2 shock is now in the range of 750 to 1,500 cc's of blood, and now we're talking about between 15 and 30% of the blood. This is a pretty broad range, but once we're getting up to a third of the blood, that's becoming very important. Here we see tachycardia, which is manifest, usually heart rate in the 100 to 120 range. Blood pressure is still normal and preserved at this point. Pulse pressure is decreased here. Respiratory rate is up, urine output is down, and the patient's probably anxious at this point and starting to have some mental status changes as this progresses. Next, we move on to stage 3 shock. This is a loss of about 1,500 cc's to 2 liters of blood. So this is 30 to 40% blood volume. Pulse rate now is very high, 120s to 140s can be even higher. Blood pressure is now decreased, and this is the first time we've seen the hypotension. Pulse pressure is decreased. Respiratory rate is increased to 30 to 40 to compensate for that lack of oxygen carrying capacity. Urine output is now almost negligible if you're monitoring this. The patient is usually anxious, confused, and bordering on losing their mental status. And finally, we get to class 4 shock. This is not something you want to see. This is a point where it's sort of do or die for the patient here. This is more than 2 liters of blood loss, more than 40% of circulating blood volume. Heart rate is through the roof, greater than 140. Blood pressure's down, pulse pressure's down. Respiratory rate is over 35. There's no urine output, and there's really, the mental status is deteriorated to lethargy or abject confusion if they're doing anything at this point. Not where you want to find a patient. So hypovolemic hemorrhagic shock is the most common cause of trauma. Trauma is well represented, I believe, on the exam. So there's 6 places that you can bleed to death initially. The first can be the scalp, and we usually say, where's the blood? This is the blood that's in the ambulance or at the scene, or the stuff you don't realize has been lost, and a lot of times this can be missed. Patients are wrapped in a sheet or they're in a C-collar, and nobody realizes that that lac on the back of their head has put out another liter that's soaked into the sheets. The thorax, each side of the chest can hold about 3 liters, so you can fill one chest cavity and be into stage 4 shock already. The pelvis and the retroperitoneum is a great source, especially in open book pelvic fractures and other sides where that space is increased. You can hide a lot of blood here. And then intra-abdominal is another source. And the retroperitoneum, this can be due to, again, pelvic is usually the source here, but there's other retroperitoneal injuries that can occur. Long bone fractures can do this, and sometimes you'll have that patient that's got a negative chest x-ray, their abdomen shows nothing, but they have 2 femur fractures and an arm fracture, and they can put 350, 400 in each one of these, so by the time you add it up, they can be progressing into a pretty significant blood loss, even though there's no one source that accounted for all of it. There are some confounders here. Young and old patients hide things. In doing geriatric trauma, one of the concepts that's really coming around is relative hypotension, and that's a drop of 40 points off of baseline. Again, you don't always know that information, but say your post-operative period and you've operated and it's post-op day 2, and your patient's blood pressure, which was living at 160, is now at 110, 120, that's probably something, and that patient is probably hypotensive and maybe seeing some end-organ damage. Their kidneys may need that 150 pressure head in order to be perfused, and their mental status due to the nature. So that's something to watch. The young also. Children will hide shock until the bitter end. And so once a child starts becoming hypotensive, they're very close to dying. It's just that their compensatory mechanisms are so good that they maintain right up until the bitter end, and then they sort of fall off very quickly. Again, a high index of suspicion is always needed based on the mechanism or what you're looking at. Athletes are often bradycardic. If their resting heart rate's 50 and they're going 90, they are tachycardic, even though none of the monitors are ringing or going off. The severity of injury can collapse. The time from injury, what may have been done in the field. Did they already get 2 liters of fluid that you're not aware of? Have they been given blood on transport? And what medications did the patient receive? Were they agitated? Did they get a bunch of sedatives? These can be confounders in sort of that initial assessment. Major soft tissue injuries and fractures, again, lots of blood loss can go. And in addition, all of this damaged tissue will eventually become leaky and edematous, and you lose a lot of fluids just into the bruising and contusions that go around these injuries. So another question, which of the following is diagnostic of cardiogenic shock? A systolic arterial pressure of 100 millimeters of mercury. B, hypotension lasting 15 minutes. C, pulmonary capillary wedge pressure of less than 18 millimeters of mercury. Or D, cardiac index less than 1.8 meters squared per minute. That's right, it's defined by the cardiac index here in cardiogenic shock, less than 1.8. So this is severe cardiac output depression and sustained systolic hypotension despite elevated filling pressures. So that's a lot of talk, but basically you can't really make this diagnosis until the patient is volume replete. What we're saying here is that despite the fact that you've put all the fluids back and that the CVP and the filling pressures are good, you still have low cardiac output, and that's part of this definition of cardiogenic shock. There can be a lot of causes here. Again, there's intrinsic myocardial infarctions, any valvular issues, arrhythmias, all of these things like AFib can lower your, acute AFib can drop your cardiac output by about 15% in some people with the atrial kick. And then there's obstructive causes, and in the surgical or trauma setting, this includes pulmonary embolism, tension pneumothorax, and pericardial tamponade. We'll talk about each of those as we progress. This is a nice diagram sort of showing the death spiral or the pathophysiology of cardiogenic shock. You start with some myocardial dysfunction. As the systolic function goes down, you lead to hypotension. It leads to more coronary decompensation due to inadequate blood flow to the heart itself. You have hypoxemia, which can also arise, having pulmonary complications, and then this leads to more ischemia. And so you see that all of these things sort of potentiate as the spiral goes on and on. As we start losing each one of these things, it feeds back and causes more loss of myocardial activity, eventually leading to death. The cardiac diagnosis, again, for cardiogenic shock is hypotension, usually systolic less than 80. It has to be persistent for more than 30 minutes. And then reduced systolic cardiac function defined as a cardiac index of less than 1.8. You have tissue hyperperfusion. Again, two of the best indicators of tissue hyperperfusion will be mental status and urine output. Probably two of the most sensitive organs to low blood flow are going to be your kidneys and your brain. And then increased left ventricular filling pressure. If we had a Swan-Ganz catheter, the pulmonary capillary wedge pressure would be greater than 18 millimeters of mercury, meaning you're adequately filled. And so that wedge pressure is a surrogate for left ventricular and diastolic pressure and how much your preload is. If it's over 18, you've really maximized preload. The reason that number 18 was set is because above that number you get flash pulmonary edema. And so now you lose track. So you really can't drive someone's filling up much more than this without compromising your lungs. Sepsis is another area of shock and something we see more and more. This is a leading cause of death in ICUs. Overall, 11th leading cause of death. There's almost a million cases a year now in the United States of sepsis. Probably spend $17 billion. And again, this is a cost number, so it's hard to say exactly what that means. But this is an expensive actor. Septic patients are highly resource intensive, can be in the hospital for quite a long period of time, and have significant morbidity and mortality afterwards if they survive. So severe sepsis occurs in about 30 to 50% of patients. We'll talk a little bit more about these definitions. Some of you may be reading that sepsis definitions are in flux, and there's a lot. That's nothing to worry about for this exam. It was written before any of this changed, and the semantics of whether it's severe are not important. Septic shock is about 50 to 60% of patients. This was a study out of Pittsburgh by Derek Angus looking at shock patients, and one of the critical findings here was looking at acute organ dysfunction. And this is kind of interesting for prognostic information. If one organ system's out, this occurs in almost 3/4 of patients, has a mortality of 21%. Two organ systems go out, this occurs in about 20%, but now your mortality is 44%. By the time 3 organ systems have failed, mortality approaches 65%. You see that's almost a geometric increase with each successive cascading organ failure. Your chance of mortality increases. So how are these all defined? Sepsis, severe sepsis, and septic shock. First we'll talk, which of the following is or are part of the SIRS or systemic inflammatory response syndrome criteria? A, temperature greater than 38 or less than 36. B, heart rate greater than 90. C, respiratory rate greater than 20 or a PaCO2 of less than 32. D, white blood cell count greater than 12,000. Less than 4,000, or greater than 10% immature band forms. E, all of the above. That's correct, all of the above. These are the 4 SIRS criteria. If 2 of these are present, we say that the patient has SIRS. So again, the temperature elevated or depressed, above 38 or below 36, tachycardia, respiratory rate of greater than 20, so they're hypoventilating, or on the blood gas, the CO2 is now below 32, or elevated or decreased white blood cell count, or a high immature rate. Again, this can be confounded by other things, but one needs to recall that low number. Many times it's a hallmark of impending sepsis, death. Once that white blood cell count falls down to 2 or 1 and you are actively infected, it means that the body's sort of given up and is not helping to fight the infection. So sepsis is any SIRS, any presence of SIRS or 2 or more of those criteria when it's due to an infectious process. And that is just the loosest definition. 2 of those are present, there's an infection, that's just sepsis. Severe sepsis is when that sepsis is associated with organ dysfunction, hypoperfusion, or hypotensive. So now you're starting to have the acute kidney injury, you might be on the ventilator, the blood pressure is getting soft, you need pressors. That would be severe. Septic shock is a sepsis-induced hypotensive state that despite having adequate filling pressures, meaning you've given all the fluids that patient needs, given them blood, despite all of that, they still have perfusion abnormalities requiring pressure agents, so that would be septic shock. They're still hypotensive despite your best efforts to resuscitate. You can see here another Venn diagram. SIRS is a big area. Pancreatitis can do this, trauma can do this, burns can do this. They're all non-infectious, but they're all part of that. Within that, when there's infection, the overlap there is sepsis, and then within that is severe sepsis and septic shock. Early findings in sepsis include increased heart rate, increased temperature, decreased oxygen utilization, and decreased vascular tone. So that venous return, the SpO2 is now elevatedly is higher than one would expect. So you have a patient who has inadequate oxygenation of the tissues, yet when the blood gets back to the heart after circulating, 80% of the oxygen or 85% is still left. So this is really due to a physiologic shunting that's occurring at the capillary level, where that blood and oxygen just for some reason are not getting to the tissues, and it's all coming right back down. So you may have 8 liters per minute of cardiac output, 100% sats, and what you're getting back is 8 liters with still high sats. So there's some sort of physiologic shunt going on. Decreased tone, your vascular resistance will decrease. Later on, you can see normal to a low heart rate. Sepsis-induced cardiac dysfunction occurs in about 30% of patients, where you'll see echocardiographic anomalies and decreased cardiac output just due to the sepsis. And then vasodilatation. These patients, unlike all the other classes of shock, will feel warm to the touch and flush. Neurogenic shock is yet another class, and this is impairment of the descending sympathetic pathways. Remember, the sympathetic pathways come down through the stellate ganglion in the neck at the C1 to C5 level. So these are very high injuries. This can be from a central traumatic brain injury or from very high neck fracture. But you lose that sympathetic tone. That results in a complete loss of vasomotor tone because the sympathetic keeps your arteries and your veins toned on both sides. And actually, probably more important in maintaining is to keep that venous tone so that cardiac output is increased by preload increasing. There's vasodilatation, a lot of blood pooling in the lower extremities, venous pooling in the hypotension, and bradycardia. Remember, the vagus axis is sort of will sit and slow the heart down. Usually you've got all the sympathetics keeping it elevated. You remove that sympathetic outflow by, say, a high fracture or brain injury. Now all you have is vagus unopposed, and so you'll see a bradycardic patient. Spinal shock is related to neurogenic shock, and this is a constant confusion. But this is the flaccidity or loss of muscle tone that results in reflexes following spinal cord injury below that point of injury, and there's also a loss of vasomotor tone there. This can be transient. It will often recur. One of the big differences is that usually in spinal shock alone, you will not see the bradycardia or the cardiac manifestations because it's below that outflow. So if you were to, sever the spinal cord at C7, which is after all the sympathetic outflow, you would have spinal shock, but not complete neurogenic shock. If it's a C2 lesion, up in that level, you've stopped breathing. Now you have both complete flaccidities, an element of spinal, but also the neurogenic component of shock, because now you have a complete loss of sympathetic outflow entirely. We have a question. 78-year-old man presents with a history of steroid-dependent asthma. He's in septic shock due to an anastomotic leak. His PA numbers are all pretty normal. What's the most likely cause of his hypotension? Pulmonary artery catheter. Hypovolemic shock, cardiogenic shock, adrenal insufficiency, neurogenic shock. That's right, adrenal insufficiency. So this is an element of testmanship. If they're going to, when you read questions on this test, if they're giving you information, it's probably relevant. And if they start telling you that the patient happens to be on prednisone for life or something like that, they want to lead you a little bit in that direction. So pay attention to those aspects of the STEM. And here we said steroid-dependent asthma, so that just for, even if you don't know what the topic is or what we're talking about, pick the one related to steroids because they told you something. And so a certain element of testmanship will get you through some of those questions that are not in your area of expertise, and you might even get it right even though you don't really have a clue what's going on here. So this is normal hypothalamic pituitary access. The hypothalamic gives you your corticotropin-releasing hormone to the pituitary. Then we get ACTH, and then the adrenal will release its normal action in tissues of cortisol. These negatively feed back. So the cortisol is a steroid hormone circulating in plasma, small, more in its free and active form. It's secreted in a diurnal rhythm in most normal, well individuals. It binds to glucocorticoid receptors in the nucleus. And it's metabolized by both liver and kidneys into its inactive metabolites. Main actions are cardiovascular. It has a vital role in the maintenance of vascular tone. Endothelial integrity, vascular permeability, distribution of total body water within the body, and within the vascular compartment. So these are all important. So the cortisol, again, when we talked about that in the stress response, if you think about what the body needs when it's stressed, it needs blood pressure, right? And so bringing that fluid into the vasculature is what we wanted to see and maintaining it there. It also decreases the production of vasodilators, and it potentiates the vasoconstrictor mechanism of catecholamines, epi and norepi. So having both present, you get more of you get an additive response. It also has immunologic effects. This blocks synthesis of many of the interleukins, 1, 2, 3, 6, TNF-alpha, all the inflammation. So it's sort of a brake mechanism on an overexuberant response, and that's why we can use this to treat inflammation as a drug. Also, it stimulates anti-inflammatory factors and decreases local inflammatory action. It has metabolic effects. Again, this comes to the rescue and increases blood glucose. This stimulates gluconeogenesis. It stimulates glycogenolysis, lipolysis. It inhibits glucose uptake in the fat cells. And it inhibits protein synthesis, which diverts some of those amino acids toward gluconeogenesis as well. So again, this was the normal response. In the stress response, everything kicks up. You increase the stimulation to the hypothalamus, and again, the pituitary kicks up. The final signal gets down to ACTH, gets down to the adrenals. You increase, and you get more action of cortisol. What we see in deficiency is that when you have that increased stress state, however, you don't get the increase that you expect to see of cortisol. For some reason, you're sending those signals, and it's just not resulting in that increase you need. This can be due to several things. It can be due to constitutive inability to synthesize, due to, like, say, asthma-dependent, steroid-dependent asthma. There's some thoughts about sort of apoplexy of the gland, and eventually, if you're in the hospital, you're sick, and you're in a sick state for weeks at a time, you eventually get to that point where you just can't keep up. with that, and you end up with adrenal insufficiency. So it's a common, often underdiagnosed disorder. This, at many times, is sort of what leaves you scratching your head when you've done everything right. You're on 2 pressors, your fluids are back, you're on antibiotics, but the patient won't get better. So this is something to consider. You end up having either that functional adrenal insufficiency or relative. Sometimes you'll find a patient who's got every reason in the world to be in full shock, full hyperactive response state. They've been through trauma, they broke all their bones, they've had surgery, and yet you test their cortisol and it's normal. And so that would be sort of a relative state. And then some of the other things that used to be done are the stim test, where you give something that the ACTH to see if the cortisol rises. And when that was used, if the bump was not 9 or better, you considered it relative deficiency. That's not really used anymore. It turns out that the variability on those labs is about 3 or 4 points. So setting a number of 9 where you're counting on 2 labs with a 3 or 4 point margin of error is kind of worthless. So now people just get the level. If it's below, I know we use 17, give the steroids above, then it's probably okay. So now getting on to resuscitation. So again, diagnosis and treatment should be simultaneously. The best example of this is you have the patient come in, you hear no breath sounds on the left, their trachea is deviated and they're hypotensive. You can get a chest x-ray, which is diagnostic of your tension pneumothorax, or you can just put in a chest tube and both diagnose it when you get the whoosh of air and treat it at the same time. In this state and in the active resuscitation, if you have a maneuver that's both diagnostic and therapeutic, go with that. You don't want to be the guy that's showing the x-ray with the trachea on the other side of the body. You don't want to have ordered that. So standard approach is, again, the ABCDEs. So A is for airway. You need a secure airway. If you're not delivering, if you're not getting oxygen to the blood, there's no point in circulating the blood. So the game is over until you are getting oxygen, until you have an airway. Just be wary. A laryngeal injury, a right main stem is very common, especially in a stress situation. People get excited and just put that tube in as far as it goes. So which of the following injuries here are considered life-threatening? Tension pneumothorax, pericardial tamponade, open pneumothorax, massive hemothorax, or all of the above? That's right. All of these are things to recognize. These are really easy to write test questions about and give those to you in a scenario, and they're very easy to clinically correlate some of trauma and shock. Tension pneumothorax, open pneumo, and flail chest are all sort of related. So tension pneumothorax occurs when there's a flap valve created, so there's an injury to the lung. Air is able to escape into the pleural space but cannot return. So with each and every breath, you get more air out, none in, and eventually the entire lung collapses. And then after that, you put pressure on the heart, the space continues to expand, the trachea deviates, and you get to a point where you can't have any cardiac output because the intrathoracic pressure is just too high for any of that. It decreases venous return as well. Your IVC and SVC can't work. And the cardiac output goes down. So this is a clinical diagnosis. This should be made with a stethoscope or anything. So absence of breath sounds on one side, hypotensive patient, the trachea may or may not deviate, neck vein distension, tachycardia, respiratory distress. Patient comes in, they're in horrible shock, you can't hear breath sounds. That's, unless they're right main stem, you should probably think about putting in that chest tube. The worst case scenario is you put in a chest tube. But that's something that you should probably jump at before doing a lot of maneuvers to figure out why. Here you see the x-ray you shouldn't order. You can see that everything is completely deviated into the left chest and a complete absence of anything on the right. So tension pneumo is a surgical emergency. If you have limited resources right away, you can do a needle decompression. This is done at the second intercostal space above the rib, not right below. You should see a rush of air. Once you've done this procedure, you do need to go ahead and put a chest tube in. If there was no pneumothorax, you may have caused one in doing this, but you need more definitive draining. One caveat in practice is that about 50% of these that have been put in the field are not in the lung or the pleural space. When we get the CT scans, we find frequently that it's not in. So if you get them to the scanner and it's been put in the field and they're okay, you may realize you don't need that chest tube because the needle never got in. As the BMI goes up, the chances of a short angiocath getting in and staying in are decreased. Tube thoracostomy is definitive treatment. Open pneumothorax, this is the sucking chest wound. This is complete equilibration of pressures between the outside world and the intrathoracic space. This leads to severely impaired ventilation because you just can't maintain the bellows mechanism. That lung is out of commission because you can't maintain any sort of pressure to get it to expand. So you get hypoxia and hypercarbia. Here's an example on the photo. You can see that this back is just completely exposed in the chest cavity. The treatment here in the field is a 3-sided dressing. You can put this on. This will allow the egress of air out through that one flap if pressure increases, so you don't create a tension pneumothorax if the lung is injured underneath, but will not allow more air to go in. So it's possible you can get some re-expansion without causing tension. Eventually, thoracostomy tube done at a point away from that with repair of the defect is the ultimate treatment. Flail chest and pulmonary contusion. A flail chest is a segment of the chest wall where you've had more than 2 ribs broken in more than 2 spots. So you have one segment that moves paradoxically with the rest of them. This can be a damaging and troublesome injury because if you've taken enough force to break that many ribs and that many spots, the underlying pulmonary contusion is probably the most severe effect here. In addition, it's incredibly painful to the patient to have the rib cage moving paradoxically, and so they will splint and will not breathe for you. Best way with either a pressure dressing or something to try to maintain that can be there. Treatment is supportive. There are now people doing rib fixation, but that is not an acute procedure. That's something to be done down the road. The initial treatment of all forms of shock is vasopressors, A, B, blood products, C, invasive hemodynamic monitoring, D, crystalloid bolus. That's right, a crystalloid bolus. So you can't go wrong with giving a liter of fluid. We found that giving tons of fluids, I know when I trained, if you didn't give 30 liters to a trauma patient, you weren't trying hard enough. That is not the way we do things. That's how we were causing ARDS and a whole lot of trouble at the time. But it is always the start to resuscitation. Just you do it up until it's not working and then stop. But first answer, give a liter of fluid. So circulation is the C. You want to assess tissue perfusion. First thing you can do is feel for pulses. If you've got a good bounding groin pulse, you got at least 80. If you can feel peripheral pulses, your systolic is over 90 or 100. If there's obvious hemorrhage, this is part of C. Control it. Direct pressure, tourniquet if needed. Whatever it is you need to do that. You can also do, if you have an open book pelvic fracture, you can feel sheeting or a teapot or a binder to the pelvis, again, can help with that. Vascular access is the third part of the C component that's important. Is you need to get 2 large bore IVs. This is greater than 16 gauge. Do not put a triple lumen in. This is a very ineffective line. Remember that the resistance in the line is proportional to the inversely related to the length. So the longer the catheter is, the more resistance. But more importantly is the radius, and it's the factor cubed. So if you can go from that 16 gauge in the arm is far more effective than that foot-long 14 lumen that you're trying to use in the neck. If you need an introducer, 9 French is the way to go, right? Because then you have a huge radius and can get all sorts of fluid in. Central access if needed. In traumas, there's some teaching that suggests you get above the diaphragm in case there's abdominal injury and that you continue to lose that. Remember to use fluid warmers and rapid infusion pumps. Hypothermia leads to coagulopathy and leads to more bleeding, more shock. So you want to make sure that you're using warm fluids, because if you're put a couple liters in, 4 units of blood, and it's all frozen, your patient will rapidly cool off on you. Again, warm Linger's Lactate, it's 1 liter for adults, 20 cc's for kilo in kids. Assess your response and then see where you are and go from there. You want to get definitive control of any hemorrhage, whether that's IR, tourniquet, OR, somewhere. You got to stop the bleeding. If it's ongoing, it's game over, right? If you can't get ahead of it. And then C, we will look for massive hemothorax. Again, one side you can put about 3 liters. You can get half your blood volume into your chest pretty quickly. You know, if you got to do that thoracotomy, get it managed with a chest tube, any of those things. And then cardiac tamponade. This is only a tiny little bit of blood, as much as 5 cc's in that space can cause cardiac issues. So massive hemothorax, again, 1,500 cc's or more than a third. Usually it's from penetrating trauma. Put in a large bore chest tube. You can do auto transfusion of giving that blood back. That sounds great in theory. Logistically, it's almost impossible to keep that clean and to do that in the emergency room setting, perhaps in the OR. A thoracotomy would be the next step if you have ongoing. If it's more than 1,500, if you're putting out more than 200 or 300 an hour, you need to be either in the OR or perhaps in the ER doing a thoracotomy to control the bleeding. Cardiac tamponade, usually this is with penetrating trauma. A small amount of blood, again, can do this. You see venous distension in the neck, hypotension, and muffled heart tones. Again, hard really clinically sometimes to tell, but the JVD is probably the thing you're going to see first off, as well as the hypotension. You can diagnose this on FAST, echocardiogram, pericardial window. Management is either surgery or pericardiocentesis. For trauma, the answer is not pericardiocentesis. You do not try to drain blood through a fine catheter. It will clot the tube and you will not fix the problem. That would be more for someone who has an effusion where a cardiologist can do this under safe circumstances. But that blind stick procedure, subxiphoid through the abdomen to get blood drained around the heart is not recommended. Causes more harm than good usually. This is where you do that thoracotomy. Pericardial window, again, is something that's really not done often anymore. With the advent of TEE and echo, you can get a good picture of that. About the only time people will do it is if they're in the belly already for something else. They have ongoing hypotension. If they want a quick look and they don't have the skill set for TEE, then you can do that. But again, as the first line diagnosis for that, it's really not the way to go. We have so many other ways. There's usually an ultrasound probe sitting right by the bedside that you should be able to figure this out without going for a window. In which form of shock might dopamine be a preferred agent? Hemorrhagic shock, septic shock, spinal shock, neurogenic shock. That's correct. Neurogenic shock. Again, dopamine has some chronotropic effects, and that's what you're using it for. Dopamine really is almost never used as a pressure agent anymore, but of all of them, it does have that effect of causing some tachycardia, which is a lot of the reasons we don't use it for other things. So in a neurogenic shock case, it may be helpful. So other conditions, hypovolemia or hemorrhagic, fluid, watch which type you use. For that first liter, it doesn't really matter what you give. If you're giving lots of saline, you can cause a metabolic acidosis due to the chloride. Remember, there's nothing normal about normal saline. It's 151 of salt, 151 of chloride, which is nowhere near what we expect. So you get a hyperchloremic metabolic acidosis. Use blood early. A lot of the ARDS that we were seeing probably in the past had to do with both the ventilator strategies and the high degree of salt water that patients were being given. Hemostatic resuscitation is now, this is the 1-to-1-to-1 ratio, which is advocated in trauma. Again, this applies to patients who are getting a massive transfusion. If you're giving 2 units, you don't need 2 and platelets. If you're giving 10 units, then you want to be at that 1-to-1-to-1 ratio, or if you're giving 4 or 5. So as you start emergent, if the patient's in shock, you want to do that hemostatic resuscitation. And then get to the point where you can use labs to do that. But at least right off the bat, most places have an MTP or massive transfusion protocol, which gives you those units come sort of in a predisposed cooler with, 5 and 4 and a 6-pack of platelets or something of that sort to give all at once without thinking. You can start thinking as soon as you have access to being able to get lab results and the other things, you can stop that. It is highly resource, use a lot of blood in that. So you want to target eventually, but right off the bat, remember that that's sort of a recent buzzword is this hemostatic resuscitation. Damage control maneuvers, packing, sheeting, tourniquet, any of these can work in a fine. And then the resuscitative thoracotomy. For cardiogenic shock, here you may want diuretics or vasodilatators to reduce that afterload and get the cardiac index to go up. You're called to see a patient whose status post Hartmann's for perforated diverticulitis. The patient's hypotensive and tachycardic. The best initial treatment is bolus hydrocortisone, B, administration of norepinephrine, C, crystalloid bolus, D, broad spectrum antibiotics. There we go, crystalloid bolus. That's always a safe place to start. So in septic shock, vasopressors are used relatively early. As soon as you've got that fluid resuscitation up and you've given a few liters of fluid, your CVP is elevated, start adding the vasopressors. Surviving Sepsis Campaign talks about early goal-directed therapy, which involved blood pressure targets, hemoglobin targets, and early, very early starting of antibiotics. Don't wait for your culture to get back. The rule of thumb is if you're seeing someone who you think has sepsis, draw blood cultures, start antibiotics. It should be one swoop. You preferably, if you can, get the culture before the antibiotic dose goes in. But again, for each hour you delay your antibiotics, you increase mortality. Neurogenic vasopressors. Again, in spinal shock, Neo is a decent agent. Neo's good for vasodilatory shock. That's why it's used in the operating room all the time by anesthesia. Other than that, it doesn't have a lot of use as a pressor because it actually increases afterload, and that's what you want in this case. Dopamine, again, can be used in the stem. What you would likely be treating is a very high injury and someone with bradycardia when you look at these agents. No one's going to ask you the best agent for X is this, because if you look at this, you get 3 answers from 3 different intensive care medicine docs. But just remember in that stem what might be helpful, and remember Neo is a good choice for spinal shock, spinal cord injury, and dopamine if you have that associated with bradycardia. Adrenal insufficiency, if you suspect it, you can grab a quick cortisol. It never hurts to just give 25 or 50 of hydrocortisone and see what happens to the patient. Usually if they're going to get better, they get better fairly quickly. Invasive monitoring, arterial lines, central venous catheter, pulmonary artery catheter. The A line is very helpful. The central line is very helpful. You can put it in a position other than femoral. You can use it for filling a CVP. It's not a perfect surrogate for Swan. Swan-Ganz catheters almost rarely have to go in anymore. This there's just not a lot that you can assess with this. In cardiac surgery and with cardiac issues, it is helpful. But for the rest of it, most of the studies showed that it was more harm than good. People started treating numbers instead of treating patients, or when you gave a same set of numbers to 5 providers, you got 5 different answers for what to do with it. So they're really not in favor right now, unless you're just stumped and you think it's cardiac. Echo can do that, and we have bedside echo and all these other tools that can measure a lot of what we want to see without doing that. So in which type of shock are the CVP and the pulmonary outflow tract or wedge pressure increased? Hemorrhagic shock, cardiogenic shock, septic shock, neurogenic shock. That's correct. It's cardiogenic shock. Remember, this is decreased cardiac output despite adequate filling pressures. So when we look at a pulmonary catheter tracing, as it were to go in, when it hits the right atrium, you see a little elevation. It looks like a CVP. It goes into the right ventricle. Now you see typical ventricular waveform. Here the base will be about 0. When you cross the valves in the pulmonary artery, now you have a diastolic pressure that's about 10, so 25/10 you might see here. And finally, when it's wedged, you see everything go dampened in that final tracing, and that's when it's out into the pulmonary artery and has occluded forward blood flow. Some normal measures: right atrium 0 to 7, RV again 15 to 30 over 0. Pulmonary artery, now you have the same 15 to 30, but diastolic of 10 to 17, and your normal PA output occlusion pressure is 6 to 12. 18 is what we drive to for resuscitation because that's the maximum you can increase it to before you get pulmonary edema. Here's a bunch of other parameters, not something that's that important for you to memorize. The cardiac output is usually 4 to 7, and remember the cardiac index is derived from this. That number is 1.8. Around 2 to 4 or 3, 4 or 5 would be a better number. And then both the delivery and the venous oxygen, the O2 extraction should be about 20 to 30%. And that O2 extraction is the sats as you head out, and then that's the arterial sats, and the mixed venous sats as you come back to the heart. The normal person will extract about 25% of the oxygen, or one of the 4 carried on each hemoglobin when it comes back. If it's coming back and the saturations are high, you have some sort of shunt going on, meaning that blood is getting to the tissue but no oxygen is being removed. So that fits with sepsis. If it's coming back and that mixed venous sat is 50 or 40, that means you are extracting every bit of oxygen you can, so you're in a flow or delivery limited state at that point, so you need to do something to increase your oxygen delivery. If you're extracting it all, it means that you're just not delivering enough. Which the following are endpoints of resuscitation? A, lactate level. B, base deficit. C, urine output. D, all of the above. Yes, those can all be used. So just a couple things. This is a kind of a busy chart on pulmonary artery catheter numbers. Just remember that where the differences are. So CVP is going to be elevated in cardiac, and as is the wedge pressure. In almost all of these, except for septic shock, cardiac output is down. And then SVR in that distributive state will be decreased again in septic shock. And again, in sepsis, you are actually delivering hyper oxygenating the tissues. It's just not being utilized. Endpoints, vital signs are unreliable. You can have SIRS. You might have these other things if there's infection associated that are driving this other than whether you're in shock or not. Also, drugs, beta blockers, calcium channel blockers, any of these. Urine output is good. Again, you're not going to be able to use this. Someone with baseline renal insufficiency or someone who's sustained a kidney injury may not come back quickly to use that. Lactate is a sign of anaerobic metabolism. Serial measurements here are helpful. You should expect for the lactate to clear within 24 hours. After trauma, if you're not clearing your lactate, if it's staying persistently elevated, you probably need to do a little bit more. Same with base deficit. You want to try to normalize it. Giving bicarbonate just for the sake of giving bicarbonate because you have base deficit is not useful. Through the Henderson-Hasselbalch mechanism that converts in the body within seconds to minutes, it hasn't helped too much. During a code situation where your pH is 6.9, it might be worth giving, or some other times, but it's not terribly helpful to just treat a low pH with bicarbonate. It's just not lasting. You haven't removed the source of the acidosis. Invasive hemodynamic parameters, there's a ton of them. No good single predictor. Where now, if you look in all the magazines, they have these tissue oxygenation probes that go on the thinner imminents and other places. Again, not really in widespread use. I imagine they're expensive though. So just you got to look at the patient as a whole. Are they starting to make urine? Is the mental status improving? Have they cleared their lactate if it was elevated? All of these things can help you within that. That's what we got on shock. Any questions? Sir? Yes, it is, and that's now, we went from fast to he wanted to know if ultrasound is good for diagnosing pneumothorax in the emergency department. It can be used if it's called an extended fast. In addition to the normal 4 points, you look for lung sliding. In the right hands, it can be very useful. It's going to be confused if there's subcutaneous emphysema and other things going on. You'll lose the ability to do that. All right, well, thank you.